Welcome back to Dysphagia Matters and the second part of our conversation with Professor Joan Arvedson. In our last episode, we laid the foundation for understanding feeding and swallowing disorders. In this episode, Joanne will share her insights on the treatment approaches for infants and children with feeding and swallowing difficulties, and we'll explore the essential role that parents play in the therapeutic process. We'll pick up right where we left off last time, so enjoy listening.
And when we think about that treatment journey, what for you are the most important underlying mechanisms that we need to be aware of? You already talked about the sensory motor skills. What do you think should we as clinicians all have in our minds?
We always have to ask about their cognitive and speech and language situation as well. And are they nonverbal? Not because they have motor problems in producing speech sounds, but is it receptive language? Is it cognition? And the children on the autistic spectrum are so variable. And we just see more and more, I think in all cultures, we are seeing more and more children on the autistic spectrum. And I find that they are often very difficult to help direct attention. They don't manage change easily. Routine is really important for them. But we know that, again, very systematic changes, and maybe it's from touch to smell to allow it on the tongue. We won't even go into all of those kinds of things, but all of those things are important. And I think also the overall core strength. So I'm always asking about sitting independently, how do they move, and what kind of assistive seating do they have? Because we also know that there's no point in working at the mouth if position, posture, seating support is not adequate. And I would well suspect that a good many people have found that when you get those pieces in place, you don't have to work so much directly at the mouth. So considering the whole picture is really important. I also always ask about hearing. Did your child pass newborn hearing screening? Is there a hearing loss? Vision, because all of those sensory aspects, again, we don't do anything directly with them. But I have found that in a good many years I've been at this, and I keep learning, which is why I keep doing it. Part of why I keep doing it, that we know that we never know enough, but we also know how interrelated all of these kinds of things can be. It is also true that there are some children, probably with major neurophysiologic, neuromuscular diagnoses, and some of them are progressive, meaning they're going to get worse over time. Then we have to adjust the recommendations, but it doesn't mean that they're just stuck with the tube and they don't do anything else orally. They have saliva. They need to be swallowing saliva. And we also know that oral care is absolutely critical. So toothbrushing, seeing a dentist, and I will say to parents, we always talk about never force feed, never force food into your child's mouth, but you got to brush their teeth. Well, if they don't like it, and a lot of them don't, isn't that almost like force feeding? So I find some of those kinds of almost contradictions. I say you just have to figure out a way, and maybe it's with a finger brush, maybe it's with a washcloth initially, and you do it as quickly and as well as you can, but as least stressful as possible. And children change over time. That's the other thing that makes this area of our professions so critical. And I find that this is the one area where, as a speech pathologist, could be some other therapists as well, but we're talking about really working with the mouth with the speech pathologist now. It is the one area where we can actually do harm to children. I think in all the other areas in which we work, we might not be so helpful, but we're not harming them. But if we're making recommendations or there's follow-up where we may be actually increasing the possibilities of pulmonary problems or the inappropriate developmentally approaches, but that could harm these children. And it may be that with the insights that you have about how these systems relate together, the best thing you can do is to help to facilitate that the child gets to the specialist they really need, whether it's for neurologic testing, something more in terms of GI testing. And I have had parents come to me maybe a couple of years after I've seen the young child once or twice and say, Dr. Arvedson, you saved my baby. What are you talking about? I saw him and we figured out that he really needed to see neurology. Yes. And they found a brain tumor and he had surgery. So if we are not always trying to say what else and making sure that we function within our scope of practice, and I think a couple of the questions that you've been asking are really getting at that, then we are not being truly professional either. So I think it is one of the most difficult, challenging, and yet rewarding areas that we can possibly work in, because every little step makes a difference. And when I work with children, I don't see a lot of them for ongoing intervention. And when I do, it's probably at 3 or 4 week intervals because I'm coaching parents. But that's what it's really all about. So it's knee to knee with parents. They're not watching from a one-way window. They're in there working because that's where it really makes a difference. And we also know that kind of regardless of what the focus is, whether you're working to get a child to accept a spoon, or you're doing more about it, nipple feeding, or you're helping them with chewing, or probably some combination. Brief and frequent practice sessions, because you're asking a little bit more about intervention. So you need to, and the home practice is where it really makes a difference, but you've got to coach these parents too. And I will say, you're probably thinking, this is so simple, why didn't I think of it myself? Well, it is simple, but it's not intuitive. So if it would have been intuitive, you would figure it out yourself, but it isn't intuitive. And that it's very important that you stop before a child gets all stressed. So you end when I'm pretty sure you would do just a little bit more. Why do I stress that? Because children remember how things end. And they also know it's pretty powerful. If you start fussing and crying, toss the spoon to the floor or whatever, what do parents do? They rescue. And they don't even realize that they're rescuing. And our psychologists will tell us, and I work with some excellent feeding focused psychologists, and we don't have, I think, almost in any of our areas, enough really well-trained psychologists. They do some of the things that speech pathologists do, OTs do. It's about communication and some other things. But if we just think about what the discipline of behavioral psychology brings to all the aspects of feeding, they will emphasize too that you want to not rescue children, but to respond to the cessation of fussing and crying. And that holds to a lot of different kinds of situations as children grow up. And another very important thing, and I bet you won't find this in the literature anywhere either, is I never ask a child, are you ready to get in the high chair? Are you ready to eat? Do you want? Unless no is okay. Because if I ask a question that can result in a no answer, then I must respect it. And then you're done. But how many times, and I'll catch a lot of people, therapists as well, doing this. It's time for a bite, okay? Well, you tack that okay on the end, and that's asking for permission too, isn't it? So these things carry over beyond feeding and swallowing, but we're talking about the focus on feeding and swallowing with these. And it means that we, as clinicians, have to be aware of all of these things ourselves. And also, I think always looking for, where is this child today? Where do I anticipate tomorrow? Knowing that we have no way really of predicting, and we have no way of truly controlling anybody else or what happens. But the knowledge in, I mean, I could list all these disciplines, and you all know them. But how do we do that and make it still doable for us, when it would be a whole lot easier if I have a little set of tools and can just say, okay, I'll do this one or I'll do that one. So I think that's the constant challenge. And it never gets boring.
Yeah, and I guess that's again true for so many different fields or areas within our speech therapy field. And I really enjoyed you describing those behaviors. I think most people can relate to them, either having done them ourselves or having observed others. And it's so difficult to not do them, I can imagine, because I guess if a child is crying, then you want to end it immediately or as soon as possible. And then, of course, you might behave differently than what you know is maybe the best behavior. So, yeah, thanks for sharing that. And earlier, you also said that we as therapists can do quite a lot of harm if we do things maybe not ideally. And I think that's also something why speech pathologists are afraid of working in this area. So maybe to take off this fear of working in this field and to maybe train people better, can you explain things that we need to know or underlying systems that we need to know of that support the development of swallowing and feeding? So anything that we should consider when working with these children?
Well, I think to start with, hopefully in our graduate programs, and I don't think that this is always the case either, or even as an undergraduate, do people get basic physiology? Do they get neurodevelopment? Do we get in any organized way what I very briefly described about embryology and then fetal period, prenatal development, as well as very early development? I don't think that happens in very many of our academic programs. And even in terms of the speech and language, I think that there is more emphasis now on infant sound development and that sort of thing. But then can we also bring into that more of the underlying physiology? Now, I think the other thing, it's like, what do we know about the gastrointestinal tract? What do we know about nutrition? If we just take the things that we can notice beyond, what do we know about the pulmonary system? And what are the effects of aspiration? And it's not all or none. And I think that as we gain more knowledge, we have to raise the question too, that if we have thickened feeds, might that be more harmful to pulmonary system, even with less frequent aspiration, than if they're getting water or breast milk or a very thin liquid, because we know that the lungs are water soluble, but we don't know how much of what they can handle before there's a problem. So that's one of the big questions that we have to keep asking. I think we also need really good mentoring. We can't learn it all in academic programs. And you would know, I mean, I didn't have any of that years and years ago. I spent the first half of my career focused on adults with neurologic kinds of aphasia and dysarthria and that sort of thing. So that's one of the pluses, though, about the whole field of speech pathology, is that we do see such a range of populations, that there are options for people. And that's a very positive thing, that just because we get started in something doesn't mean we're stuck in the NICU for the entire career, or head and neck cancer for an entire career. But we have to then take what we know from one environment or types of individuals, I'm just going to say, and then be able to keep learning. And I find it really difficult to be as precise as I would like to be, but I think that's okay too. But the key thing is mentors, so that you don't want to be too independent too early in your career. And you want to have some kind of a team, not just other people in your same profession. But we learn, for instance, in an aerodigestive clinic where we have dietitian, pulmonologist, gastroenterologist, otolaryngologist, speech language pathologist, and then we're seeing these children in a group environment, and then they're being followed elsewhere because we're not seeing them every single week. But whatever environment that you're in, and however you can figure out how to work with other people to develop teams, I think that's an important part. And it can differ so much. And we need people in rural areas. We need people in underserved areas, and the differences in resources that we need to think about as well. We did a recent review article that Maureen Lefton-Greif was the primary author in Dysphagia just a few months ago, and where we really tried to review the differences in resources in different countries. What kinds of resources are available when you cannot get an instrumental swallow evaluation? How do you make safe, the best possible decisions? And I think that if we are always keeping in mind that there's no one way, there probably aren't even just 2 or 3 ways, but caution, make changes in very small steps. And if we are monitoring and asking the parent questions, are you concerned about your child's weight gain? Or what does the dietitian say? Well, they haven't seen a dietitian. We encourage you to go back and talk to your pediatrician about the possibility of getting some additional guidance from a dietitian. I think those are really important factors in whatever environment we are in. Schools as well. And all of these really high-risk children get into some kind of a school program, right? Where whatever country you're in, and some maybe with more resources than others. So that's kind of vague, but I hope that at least lets people think about, okay, I see the child and family in this kind of an environment. How does what we were talking about on this podcast have some relevance to where I am, even if they weren't talking about it in exactly the same ways? If we can accomplish that for people, I think that's enormously helpful. And I'm so grateful for the 2 of you with this awareness that you have to even put together these sorts of things.
Thank you. That's maybe another good question. What role does neuroplasticity play in the development of sucking and swallowing?
We do have some basic research, animal research, as well as some adult research and more research now in pediatrics. When you think about neuroplasticity, I think we have to think in the broad sense of that our brains do have chances to either have different areas take over or help to facilitate what can happen. And we don't have that in a major anatomic way. So I don't know that we can really say neuroplasticity in the development of sucking and feeding, but I think what we find is that the possibilities for changes in the brain, we do know those exist. But it's also true that neuroplasticity can give us this kind of variability, if you will. But it's also true that if we are training something off task, our neuroplasticity may actually work against us. So, for instance, if somebody is trying to help somebody learn to chew food, but they're really just having them chew on some kind of a tool, but without food, or even often they'll use sort of a mesh bag that has something in it, but then they don't have to worry about choking, or they don't have to worry about the total manipulation. But now what have we done? We've trained a habit, and then you have to retrain to get the function. So when I think about sensory motor learning and neuroplasticity, I think they do all interrelate. But that's where it's really important that we train as directly to the task as possible and not bring in ancillary or non-functional aspects that then have to be retrained. And I'll use a couple of other kinds of analogies, and especially as we're doing this and the Olympics are going on, this will kind of date this timing. But if I'm going to learn to swim and do the breaststroke, I better get that stroke going when I first learn as a young child. Because if I don't have the best habit then, it's going to be very difficult to change. So yes, it can change. We have neuroplasticity. There are possibilities for change, but they become more difficult the longer a habit has been in place, and probably the older we are to do it. And you could think about it in golfing and running and almost any kind of sport.
Yeah, or any motor task, probably.
Yeah, yeah.
So what would you recommend doing instead? Or what do you do usually?
Do it in very small steps gradually. So instead of putting crumbs on a tool of some sort, I will go from a drop of water on a spoon at the tip of the tongue. We're talking here probably a child who's in transition feeding stages, sort of developmentally 6 to 9, 10, 12 months. And then just a little bit more. And you've got to watch to see, will they open wide enough so you can put the spoon on the tongue, slide downward pressure and bring it out along the tongue, which encourages lip closure. That's where you have to really know and appreciate the normal function, even if it doesn't appear to be, I used the word normal. Scratch that one. I don't think we know what normal really is, what is functional, what seems to be appropriate developmentally. And then even with the chewable food, what is the most important thing about that? That it goes into the side on the molars, even if they don't have teeth. And it has to be something that if they munch up and down once or twice, it'll start mixing with saliva and get soft. So it becomes almost like a puree. And it doesn't have bunches of pieces across the mouth, and then they're going to learn to do that. And they're going to learn to do it in a way that is not stressful to them. So I think it still comes back to, what do we really know about the advancing and of the skills? People talk about baby-led weaning. So that's another whole topic as well. Some children can probably handle that, but others, no. I did an invited editorial for a Brazilian pediatric neurologic journal last year in relation to a couple of studies. And I've had so many requests to give additional talks and present more research with this simple little 2-page editorial, where I stressed, when people talk about having parents describe gagging and choking, they're not even really well defined. So some people talk about choking when it's probably just gagging, and gagging is really a sensory response, because people will gag without anything going into their mouths, right? And then what about the nutrition? So are they really getting the trace nutrients that they need if they're taking probably primarily carbohydrates? So I don't have the answers to those, but we raise the questions, and then people follow through back to the pediatrician, to the dietitian, and you can work with the skills, help to coach the parents in very functional sorts of ways, but never in isolation, and with always these added questions to say, what else might be going on? What else do we need to think about? And how do we do it so that it's just not stressful to the child? I also emphasize that you've got to tell a child what's happening. Here comes the spoon. Time for a bite. It's not zoom, zoom, zoom. Here comes the airplane.
Tell them and not ask them.
Yes, tell them, not ask them. And then when they've done it, you took the spoon. I like the way you used your lips, or something similar, and not just good job, good boy, good girl. Those things are not intuitive. I mean, it's intuitive to do the good job, and that's okay. That can be a part of it. And I think that what's really important is that we help parents to realize that when we give these suggestions, it doesn't mean that what they were doing is bad. It means we'll take something that's working, maybe not working so well, but maybe working fairly well, and help it to work even better. So we're not good or bad, right or wrong, but how can we take what this child does and keep it short and focused? It's also important to emphasize to parents that, especially once children are moving around, children need to be seated and supervised for all eating and drinking, not walking around. I've also done consulting with some major food companies when they're coming out with new products for young children, risks for choking, and also legal aspects when children have walked around with food and aspirated, choked, whatever, and some of them have died. But if they're seated and they're supervised and it's time limited and there's nothing in between except water if they're thirsty, and safe to do that, because we want to facilitate hunger and interest. And that's why there are so many complicating factors, but they can be developed into some very practical and functional approaches with respect for the parent, for the culture. And not everybody eats as a family, and they don't all sit around a table. So you really have to find out those things as well. I also believe that it is okay to ask parents if the child pees and poops okay, if they have any problems about constipation. Again, are we going to do anything about that? No, but if parents report that a child is constipated, that's going to have an effect on how they eat and drink and how much they eat and drink. And that needs to be attended to. So that's where you help by getting back to whoever referred the child. Because remember, for the most part, we're consultants. So it's not like we just send them on to somebody else, but we get back to whoever referred and then make these suggestions for these reasons and maybe help to facilitate additional follow-up as well. So it's not just what we do with the mouth, it's how do we work with others and how can we coach parents and affirm the primary caregivers, take it in little bitty steps that make a lot of sense.
Thank you so much, Joan. I think we could continue this conversation for hours and hours, but we've come to the end of this episode. Is there any advice or insight that you would like to share with clinicians working on sucking and swallowing in infants?
With the very young infants, it's the same basic principles about no perfect nipple. And in a sense, you've got to make sure that the flow is not too fast, not too slow, and that they are calm and be able to keep those patterns going, suck, swallow, breathe in coordinated ways. So with the things that we talked about early on, I think help to play into this. And again, time limited as well for those infants so that they need to feed within probably 20 minutes to no more than 30 minutes on a regular basis, breast or bottle or combination, because some parents will come and they're telling us that they're feeding for almost a whole hour. That's not going to be the best way because now you're already impinging on the next feeding time. So time limited, efficient, simple adjustments, maybe positioning adjustments. It may be something about the flow of the nipple, but the literature, and there are a couple studies about nipple flow, there's a great deal of variability within brands and across brands. So we really have to always be looking for what's going on with that individual baby and those particular caregivers on the basis of a lot of knowledge and experience.
Yeah, and take small steps like the turtle and don't put any stress on the children.
That's right. And amazing things will happen over time.
Yes, thank you so much, Joan, for taking the time and sharing your extremely valuable knowledge with us today. It was such a pleasure listening to you and talking to you.
And you all have very good questions. So that's key for you and all of your listeners is to keep asking those questions. And that's the way we keep learning. And that's the way we keep helping these infants, children, and their families too. So thank you very much and carry on.
Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram @DysphasiaMatters, on Twitter @DysphasiaPcast, or visit our website at dysphasiamatters.org. Take care, everyone.